Good morning or good afternoon. I'm Monica Pica with Sachs Healthcare, and I will be your technical producer for today's webinar. Before I introduce our moderator, Dr. James Simmons, and our speaker, Dr. Bridget Joseph, I would like to review a few housekeeping details. Today's webinar is being recorded. You may ask a question at any time during the presentation by typing your question into the Q&A box located on the right side of your screen and pressing Enter. Our speakers will try to answer as many questions at the end of the presentation as time allows. If you experience technical difficulties, please use the Tech Support tab, also located on the right-hand side of your screen. If you have trouble seeing the slides at any time during the presentation, please press F5 to refresh your screen if you're using a PC, or Command R if you're using a Mac. And please make sure you are not behind a firewall, as this will prevent you from viewing the presentation. Our moderator today is Dr. James Simmons. Dr. Simmons is currently a hospitalist nurse practitioner at St. Francis Medical Center in Los Angeles, California. He is a guest lecturer at both the UCLA School of Nursing and the University of Illinois Chicago College of Nursing Acute Care Nursing Practitioner Program. He is a clinical ambassador for the CDC's Let's Stop HIV Together campaign and has emerged as a leading voice advocating for marginalized communities in healthcare. Dr. Simmons is also continuously featured as a health expert on national television, radio, podcast, and social media programming. Welcome.
Thank you very much, Monica, for that lovely introduction. I appreciate it. And good morning or afternoon to all of you. Thank you for tuning in. All right, the title of today's webinar is A Fresh Perspective on Traditional Clinical Monitoring. Ooh, I love a fresh perspective. And speaking today on this very timely topic is an expert in this area, Dr. Bridget Joseph. Dr. Joseph is a certified clinical nurse specialist and resuscitation nurse specialist and resuscitation committee chair. She has implemented many quality improvement initiatives and published research related to all aspects of resuscitation. She's previously worked as the director of simulation education. Additionally, she has worked in a variety of fields and specialties as a legal nurse expert consultant and interprofessional education consultant. Dr. Joseph has been an invited speaker at numerous medical conferences. Welcome, Dr. Joseph. Don't say anything, just wave. There you go. All right, so Dr. Joseph does have some disclosures she would like to present. She's a speaker with Stryker, a consultant for Nuvara, and the CEO of Thriven, a healthcare consulting company. So here's some of the good stuff. This session is good for continuing education for nurses and respiratory therapists, okay? A link to obtain CE credits will be available at the conclusion of the webinar, okay? So we'll go over how you can get those at the conclusion of the webinar. And of course, a very special thank you to Philips for your support of this educational activity. All right, more particulars coming at the end, and I'll handle all of the questions. So don't forget, if you have questions, put them in the chat. We'll go over those for about 10 minutes at the end of the presentation. And now I turn it over to Dr. Joseph.
Thank you so much, Dr. Simmons, for such a lovely introduction. And before we get started, I want to thank you guys for being here. And also, I do have a bit of laryngitis that I'm just getting over. So I am sipping some ginger tea, I'm sucking on a lozenge, and I haven't been talking, so I'm trying to keep my voice as strong as possible. So bear with me if any squeaks come out. So I want to talk to you guys today about a fresh perspective on traditional clinical monitoring. I'm pretty excited about this topic, and I want to speak with you guys and so that we can talk about the technological needs for ideal clinical monitoring of these patients. I'll talk to you guys about the optimal practices in clinical monitoring, and then I'm going to go through a couple of case reviews to kind of support the clinical monitoring needs, common pitfalls that you guys probably see all the time in monitoring, and some prevention strategies, so what we can do from there. So I do want to get things started just to kind of find out where you guys are with monitoring. I feel confident I monitor my patients optimally right now. So Monica's going to let you guys know how to go from there. and now to answer the polling.
Thank you, and give your voice a little bit of a rest. As you can see on the right-hand side of your screen, the poll has popped up. Please make sure you're not in full screen mode in order to participate in the poll. And the question reads, I feel confident I monitor my patients optimally now. And there are 4 choices. Is it without a doubt? Is it I'm relatively confident? Is it I think I do? Or is it monitoring patients? Never heard of it. So if you can, go ahead and choose the best answer that fits your situation. And we appreciate you being here today, and we appreciate your feedback. So once again, the statement reads, I feel confident I monitor my patients optimally now. So go ahead and choose the best that fits your situation, and I will turn it right back to Dr. Joseph as soon as we get all your answers in there, and she will certainly discuss those results. Thank you. Back to you, Dr. Joseph.
Thank you. I muted for a moment. So I think it's just important because I do think we do a lot of monitoring of our patients, and it's really important to kind of know where we are and how confident we feel. And it looks like the poll answers have kind of come in. So it looks like for the most part, without a doubt, 14% of you guys think, yes, I nail it. I'm optimal at monitoring. 68% of you guys are relatively confident, and 70% like, I think I do. And one person's never heard of monitoring. So you're going to hear about it after today. I'll tell you that much. So it's good to kind of get that vibe before you are. So I do want to talk about one really interesting, well, you might not find it interesting, but I do. But one interesting point is I hear a lot in clinical work, between different professions, talking about monitoring versus surveillance of patients. And so, we'll document pretty regularly as nurses saying vital signs stable, continue to monitor. And that's totally appropriate and correct, because monitoring really involves observation, measurement, and the recording of our physiologic parameters. So exactly that, our vital signs. We're documenting our vital signs, looking, yeah, they look good, boom, we'll continue to look at them. Whereas surveillance is more of a systemic, a goal-directed process that's based on early detection of signs of change in a patient. So it's the interpretation of the clinical implications of change. And then what we do, what is that initiation of any sort of rapid intervention that we may do for a patient. So, we are, yes, we're looking at vital signs, but then, what are we doing with that? So are we looking at every vital sign separately, or are we looking at it over a period of time? So surveillance is really the long-term looking at our patient, looking over the course of days. And when we do rounds with our, interdisciplinary rounds, we're looking at that surveillance. Where were they yesterday? Where were they a few hours ago after we intervened? Where are they now? The slide isn't showing, and I'm not sure why. Hopefully you guys can see my slide. All right, so what we think of clinical monitoring, what we're really doing is we're obtaining large amounts of data on our patients. So we're watching trends in an effort to kind of optimally treat our patients, right? We're just sitting there and we're watching over time. We want to make sure that what we're doing is positively impacting them and getting them to the end stage of discharge. So now we want to think about, when we're thinking about, we have all these monitoring, we have all this data, we're collecting all this data, what are we doing with it? Well, we want to think about what kind of devices are we using for our patients, right? We're using, which can be different, granted, based on if you're a nurse, if you're a respiratory therapist, if you are a discipline that may be on this call that I'm not calling out, but equally as important in the healthcare world And so, but we think about this surveillance, we think about monitoring our patients, and it's really dependent on where you work, what your patient population is, and what your focus is. So I'm going to bring up some of the more common devices that we use with regularity that are kind of transferable throughout healthcare fields, and that we use to gather data on our patients to support our surveillance. But there's like, a million more that I'm not going to talk about. In the ICU, you use CVHD. The numbers that you're collecting on the pressures tell a whole story for your patients. Other invasive monitorings like lumbar drain, central lines, a CVP, intracranial pressures, ventilators, arterial lines. I could go on for probably this entire hour just talking about, different monitoring devices. And I could be like, Forrest Gump's friend Bubba, who's always talking about different types of shrimp dishes. That could be me with monitoring devices. But the big difference is when we tend to think of invasive lines and when we think of monitoring devices, we don't always think of like a blood pressure cuff. We don't always think of, telemetry like an ECG. Sometimes you do, EKGs, unless you're getting them serial. Again, you don't think about just one-off EKGs as a monitoring device. A pulse ox, thermometer, a scale, a glucometer, any sort of wearable device that we may send patients home with, or our ambulatory patients, and even our stethoscopes. All of these things are patient monitoring devices. And a common reason that patients are sent into the ICU is really for closer monitoring, right? So we tend to think of like in the ambulatory area, in the med surg areas, we don't always think of those regularly used devices as monitoring devices, but they are, and it's really exceedingly important that we use them correctly to get accurate data and to support that surveillance of our patients. And we want to make sure that the interventions that we're doing for our patients are accurate. And it tends to be that the more we use something, you're all trained the proper way to use a blood pressure cuff or to use a thermometer, right? But people kind of get a little lazy because we use them all the time, and it's like, that doesn't really matter. And sometimes it may not, but sometimes it actually really does matter. So I'm going to try and change slides here. There we go. So I want to kind of I want to get us all kind of thinking so we're on the same page. I want you guys to think about a time that you've had a situation with a patient, and there was some sort of data derived from the patient, and maybe it wasn't accurate, but we intervened nonetheless. So what I mean is that maybe you were in with another patient, a PCA, tech, an MA, maybe even another nurse, comes in to tell you that a particular patient's oxygen saturation is lower. Maybe they've been consistently like 98 to 100% on room air. They've had issues with their O2 sat dropping in the past, but they've been pretty stable, getting ready to go home. So they're coming in, reporting their spot check, not continuous O2 monitoring, but they did a spot check with their vital signs, and they're saying, the patient's now 90 to 91%, and you're really busy in the other room. So you kind of run in quickly and, maybe throw oxygen on the patient, go back to your other patient, to ask the PCA tech, whomever, to go check on them in like the next 15 minutes. So now your semi-emergency is over. You can actually go in, do a true assessment on that patient with the O2 sat that's dropping, and check their oxygen, and you check it, and it's 100% at 2 liters, which seems like a huge jump, going from 90 to 91% to 100% on 2 liters of 2 liters of oxygen. Their respiratory rate, like in real life, is 15, documented as 18, because that's what happens. There's no change in respirations. So to you, it's not really adding up. Like, this seems weird, huh? Like, so you take off the oxygen, and they say, like, I feel fine. I don't feel like I'm having any trouble breathing. It was weird that you ran in to kind of give me the oxygen. So they're in no apparent distress, and they take it off, and you kind of hang out with them for a few minutes. When you're watching their oxygen, it's still 100%. So we intervened with a patient, and giving 2 liters of oxygen isn't going to kill anyone, but we provided some oxygen to a patient based on their vital signs. And then, but you have this kind of feeling, was the oxygen saturation actually 90%? Wouldn't the patient have been like in some acute distress or some sort of change, or been like, oh, it feels hard to breathe? Going from 100% to 90%, I would feel that. All their other vital signs were normal. I mean, I would probably feel like I was dying if I went from 100 to 90 in a second. So I want you guys to kind of think about this. Maybe not that exact scenario has happened to you. It's happened to me. That's why I'm talking about it. But I want you guys to, if there's something similar to that you have, in your clinical practice that has happened to you, think about that as we move ahead and as we talk about the next few topics. So, as with anything, there are technology needs. So for every monitoring device of a patient, they have specific requirements just to make sure they're obtaining the most accurate data. And as I said earlier, you learn things in school, you may learn things in clinical, you learn things when you start a new job, right? And it's always reinforced at orientation at your hospital. And if you have a nurse specialist or a unit-based educator, they're always showing you the correct way. If you follow a policy verbatim, which I know doesn't happen all the time, you're doing it the right way, the way that the device needs it. But when in reality, when you're working quickly and you're going from patient to patient and you are like, fires coming off of your feet half the day, more than half the day, and some other staff, like some more senior staff, might teach you a faster way, be like, oh, you don't have to do it that way. Connect it here and do it there. Like it's the same. It doesn't matter. A super experienced staff member might say, it doesn't matter. It's faster. So just do it this way. And they're helping you during a patient situation to attach the monitoring. So you're like, all right. I mean, they know what they're doing. They're a really good clinician and it seems to be accurate. Great. So then you can tend to pick up those habits, right? But there's a reason that there are IFUs, so instructions for use, or MIFUs, manufacturer's instructions for use, that you may be seeing around your hospital, because Joint Commission's really hot on that right now. And they're aligned with each monitoring device that we use. So devices can only monitor as accurately as we place the device correctly and meet their MIFU, their instructions for use of the device. So, I think everyone is guilty of taking a shortcut every now and again, based on our jobs and the nature of our jobs. But it is important to try and do those things as they're needed for the device. You can always give feedback to companies. You can always share with them, because they may not know that there should be an easier way to do something. But we can't have accurate monitoring of our patients if we're not meeting the requirements that the technology needs to work correctly. And that really goes hand in hand with optimizing our practices around these monitoring devices. So it's really crucial to base our interventions of our patients so that we're not doing any harm when intending to do good. And we know that the patient safety goals are to focus on, harm prevention for patients and eliminating any risk of harm to patients. And technically, poor monitoring practices are technically creating a risk of harm to our patients. Is it intentional? Absolutely not. No way, no how. But technically it is, at the risk of collecting incorrect data that we're then using to survey our patients, and then we're intervening on our patients based upon that. It seems like, holy moly. And that's like, I might seem like I'm, the chicken, the sky's falling, but Chicken Little. But really it's more impactful than we often think about. So I know that you probably think by me going through these slides, the next couple, you're going to think this lady is crazy and thinks that we have never even touched a patient. But I promise, I know that you have. And blood pressure monitoring is so basic. I totally get it. It is. But it's basic and super important for our patients. How many patients come in hypertensive crises? How many patients are, hypotensive when they're in, and we have to start them on, pressors and send them to the ICU or to an intermediate care. So it's really, accurate blood pressure monitoring is pretty critical. And technically, a 5 millimeter of mercury measurement error can lead to incorrect hypertension status classification. And that sounds like, oh, but that happens annually to 84 million individuals worldwide. That's a lot of people. That means that millions of people every day could have incorrect interventions, all because of a measurement we've all done a million times, but because maybe we placed the cuff incorrectly and did it inaccurately. So what's really important is that we have a calibrated device that, that it's at zero when we're starting. There's 0 millimeters of mercury, and that all the automatic devices have proper PMs, preventative maintenance. So that means that your clinical engineering team, wherever if you're at a hospital or at a clinic, wherever, that they're going and they're checking those devices and saying, yep, they work. And we know that PMs can kind of, I'm not always checking my PM labels, right, when I grab a device. That's on them. I should be, but I'm not. But clinical engineering practices throughout hospital systems throughout the United States have greatly improved to make sure that they are meeting all of those PMs, to make sure that our devices are working correctly. We want to make sure that you have the right cuff size for your patients and the right placement. And the right placement is that the cuff should be 2 to 3 centimeters above the crease of the elbow. And the cuffs usually have a range marked them to ensure that when you're placing the cuff, you can actually visualize that it is in the correct range. So if the cuff is too loose, the cuff is too tight, just move up and down a size. I know sometimes in the hospital, it's like nearly impossible to find a different size. So sometimes we're knowingly using the wrong cuff size because any port in a storm, you got to use what you got to use. But it's important because that's something that should be shared with your leadership, with your managers, with your charge nurses. They need to know that I had a patient and I think I was monitoring them incorrectly because the cuff is too tight, it's too small, we don't have a bigger cuff. Or you have a little cachectic person and we need a PD cuff and we can't find one. So it's really important because these things can really greatly impact the readings provided. And you try to keep the arm at heart level if you can. And it's also important to think about, with automated measurements. I know that some people prefer when we have a critical patient, that's like pre-arresting, people are like, and they don't want the automated blood pressure, right? They're like, oh no, I'll do a manual. Well, a lot of different, actually in the research, automated blood pressure cuffs are actually preferred, if you could believe it, because it takes away that interperson reliability from the different healthcare providers. So it's really interesting because so many of us are providing patient care and thinking we're doing it right, but we should be using the appropriate cuffs, appropriate placement. And I don't know if anyone else knew this, but when I was doing the research on this, I found that when you're checking somebody's blood pressure, they should always have an empty bladder and be resting for 5 minutes before you take their blood pressure. And I was thinking to myself, rest for 5 minutes? I don't have 5 minutes to sit there and wait and then check their blood pressure. So it's really, and they're also not supposed to talk. I mean, right now, that would be easy for me, but in real life, I talk a lot. So in outpatient settings, it might be a little bit more manageable, but I can't even imagine being like, shh, to every patient. I mean, sometimes it might be nice to be able to say that, but in hospital, it's really, it can be very difficult to, make sure, that they have the empty bladder, that they're resting for 5 minutes. It's really hard when we're strapped for time to be like, to have that extra time just to check a blood pressure. But we do need to make sure that our patients are accurately monitored. So I just wanted to show you guys the impacts of blood pressure monitoring just really quickly. But blood pressures can be impacted by so many different factors. The biggest ones actually is that white coat syndrome, which, my mother has been borderline hypertensive for so many years. And she's like, it's white coat syndrome. And I'm like, I don't think it is. And I kind of poo-pooed her for quite a while, but now I've had to say I'm sorry and had my cup of humble tea. But, white coat syndrome can actually increase the blood pressure by the systolic by 26 millimeters of mercury. That's huge. That's hugely impactful to a patient and to their diagnosis. So enough about blood pressure, but it is important and something to think about. So the other things are ECG monitoring. We want to think about the appropriate lead selection and lead placement, adherence to the skin. So in 2004, the AHA came up with standards about recognizing after there were really, oh, sorry, my slide didn't change. Sorry about that. But after recognizing that there are all these extreme variances in practices, they readdressed in 2017, again, to kind of create an update based on improvements in technologies and advancements in healthcare. So we monitor patients on telemetry because they either do have an arrhythmia, may have an arrhythmia, something that we're concerned about going on. And two key points when implementing, continuous arrhythmia monitoring are the electrode placement and then also the appropriate leads to monitor. So the reason that we use the 5-lead EKG or ECG, monitoring for patients continuously is to allow the patient to movement while reducing artifact. So, a 12 lead includes arms and legs for monitoring, and, obviously accurate electrode placement is key, but you can't, if you have somebody continuously 12 lead monitoring, it's always going to have artifact, right? They can't stay still forever. So 5 lead gets us as close as we can get to getting a 12 lead continuously. So we want to make sure that we have the leads in the correct placement to identify, arrhythmias if they're there, plus a decrease in false alarms. So that's going to help us with our alarm management as well. And we all know that with every beat, the heart's depolarized to trigger its contraction, and this electrical activity is transmitted throughout the body, picked up on the skin, and that's like the principle basically behind the ECG. An ECG machine, records its activity via the electrodes and displays it graphically, and that's the magic of our telemetry, right? So it's important to think about that when we're placing our leads, to know that V1 is usually the monitoring lead of choice because that's where we're going to pick up the most ventricular arrhythmias, and that the misplaced leads can cause a huge amount of misdiagnoses in patients. So if the RA lead is moved by one intercostal space, VTAC may be misdiagnosed as an SVT, or vice versa, all by just like a small little amount of movement in the lead placement. So I'm not going to go through all of the you can see the lead placement on the slide, and we know where we should be placing them. So it's important that we are checking those physiological placements on our patients when we're placing those leads. But one of the big things just is really optimizing that we're changing those leads Q24 to 48 hours. Some hospitals have that you put your initials and you date it. and I know that a lot of hospitals actually just do 24-hour lead changes to ensure that they're really adhering to the skin, that we're washing with soap and drying the skin before placing new leads, not using alcohol that can kind of, degrade the skin. And if you need to dry it, you can rub the skin with gauze, because that actually increases the capillary flow, removes dead skin cells and any oils on the skin. And it also helps to increase the ability to transmit electrical signals. So I don't know if everyone knew that, but also switching the batteries or checking battery levels can help to prevent a couple things. One, patient irritation with alarms going off, but also decrease false alarms and misdiagnosis of our patients. So next, I want to talk about 12 lead EKGs. So despite a difference in clinical use, we do use a 12 lead EKG as kind of a spot check of cardiac rhythms for patients. And the standard ECG uses 10 cables to obtain the 12 electrical views of the heart. So the different views reflect the angles at which the electrodes kind of look at the heart and the direction of the heart's electrical depolarization. So again, this is another time that it's really important to have that proper lead placement and adherence to the skin. So we want to make sure that V1 and V2 is either side of the sternum on the fourth rib. So count down from the sternal angle and the second rib insertion. V4 is on the apex of the heart. You can feel for it. You can feel that apex and boom, stick that lead. And then V3 is halfway between V2 and V4. So that's more of a dart getting it in the right spot. And V5 and V6 are horizontally lateral from V4. So not upwards towards the axilla, but you want to go horizontally. And then the limb leads should be placed on the limbs towards the heart. And again, making sure that they're fully adhered to the skin. Sometimes you get, the leads and it's like spaghetti, and people are like, and you kind of like rest the leads so that they're, the wires so that the leads are kind of like, you're like, good enough. You need to make sure that we're taking care of those leads and that they're not tangled, so that they're not pulling on the leads and negatively impacting our results. But we also want to make sure that our patients are laying down, that they're as disrobed as possible, so it's really not interfering. Clothing or anything is not interfering with the leads. And if the patient has any sort of surgical wound or train dressing in place, you want to move the lead to as close as possible to the appropriate place that it should be. Keeping in mind that all of the EKGs will have this requirement, so that would be considered the standard for this patient. And cardiology, when reviewing, will have that in mind. If a patient's really exceedingly hairy on serial EKGs, you want to clip and trim that hair to allow better adherence of the leads. And if they're super sweaty, if you can wipe really pretty aggressively, just like you would either with gauze or with a clean towel, and that will help to get rid of lotions, oils, sweat, anything that could negatively impact our electrical conduction. So next we have here is the pulse ox, and this is one that I feel like it's kind of like there's a lot of misreadings with pulse oxes. So it's a monitor used to obviously measure our oxygen level, as our oxygen saturation of the blood. And it's a plastic, it can be a plastic clip for intermittent assessment, or a stickable probe for continuous monitoring. And a pulse ox is a device that provides a non-invasive but continuous measure of the percent of oxygenated hemoglobin. It's pretty cool for a little device to be able to do that. But because of the measurement technique, it also provides the pulse rate. So that's how you can help to kind of correlate and make sure that it's accurate. That should be your sniff test. And I always say that something smells fishy, that's my sniff test. But you want the pulse rate to actually match what the patient's pulse is. And then you know that you're kind of on the right track. But the basis for the pulse ox is the Behr-Lambert law of optical absorption, which is pretty fancy, which really states that the concentration of a substance can be determined by its absorption of light. So basically, the wavelengths of oxygenated hemoglobin and unoxygenated hemoglobin are at different wavelengths of life. And on the two little LED lights that are in our pulse ox, they're highly absorbed by the oxygenated hemoglobin. And by the power of science and magic and people who are very smart, we have our monitoring device there, and that we use a lot, and that has probably helped to save cajillions of lives. That's not in the research, but that's a Bridget Josephism. So the pulse ox is about, accuracy is like plus or minus 2% on patients that have a reading of anywhere from 80% to 100%. So if you have a patient that's, pulse ox is reading less than 80%, the accuracy of that is pretty low. It's no longer really accurate. So you want to make sure that you are using the proper sensor on our patients. A finger probe will not be accurate on a forehead. So if you have the sticker, that used to happen sometimes in the ICU, we would have patients with mottled hands because, they didn't have the pressures, and we were putting them on, they were on triple pressors, really sick and septic shock. Their fingers were kind of getting bluish. So it wouldn't work on their fingers. So people are like, oh, great, I'll plop that on their forehead. That's not going to work. That it's going to give you a number. Is it accurate? Probably not. There are forehead probes for a reason. So if you need the forehead probe, use the forehead probe. If you need the nose probe, use the nose probe. Fingers for fingers. And slapping something on an earlobe, again, it might give you a number, but is it accurate? Most likely no. We've got to use and match what we should. So for interference, that can happen, with frequency. And so bright lights that are right on top of the sensor may impact the reading. Or if you have various probes next to one another. I remember walking into the room with a newer ICU nurse, and they were like, oh, I'm having so much trouble at the beginning of my night shift. And so I walk in to get handoff, and I'm like, why does every finger have a probe? And she's like, oh, I'm having trouble. And I'm like, well, let's take a few of them off. Let's start from there, and then we'll figure it out. And also, if the patient's shivering, so they're really clamped down, you might not get a good reading. And then nail polish. I know some patients come in with their lovely manicured nails into the ED or into an outpatient clinic, but it's not going to give you an accurate reading if there's any nail polish. And then, kind of as I mentioned earlier, but perfusion is huge. So we need to think about our patient. Do they have the blood pressure to reach the extremities? Are they super edematous? All of these things can impact the readings of our patients. So we want to make sure that, if we're doing continuous blood pressure monitoring, that we're checking the oxygen saturation on the opposite arm. But all of these things are greatly impactful for patients and for monitoring their pulse ox. And I just wanted to kind of show you quickly as a reminder, anything other than this normal signal up there, we should try to fix by checking the probe, altering the light in the room, maybe putting a warm blanket on top of the patient if they're shivering, and making sure that we have the appropriate the appropriate probe on the appropriate body part. So then I want to talk to you guys about scales here. So I know, again, people are like, holy moly, this weight, what a silly thing that staff, I'm not going to put all that much effort into thinking about. Especially if you have a patient that's, that can walk to a scale, you're not really thinking about how is that so important? And it isn't. You want to just make sure that it's zeroed right. You've got the patient, it's powered on, and they're zeroed. But the patient that's bedbound, we do a lot of weights. It's really impactful for our CHF patients, for our renal failure patients, for any patient that may be keeping on fluids. We check their weight all the time, right? We should be doing daily weights on these patients, checking their ins and outs, checking their weights. And we may be determining medical dosages based on the weight of a patient. When they come in, when we weigh them, we're going to be changing a medication or giving them a medication based on that weight. So we want to make sure that we are appropriately assessing our weights. So is there a standard guideline for zeroing a patient? Is it like a pillow and the mobility transfer sheet and then zero it? Or no pillows, no nothing, just the patient, and then you could subtract what the other things weigh? But it should be the same for every bed and every area, and everything other than the patient. Those items should be removed from the bed when weighing the patient. So I know that there used to be, people used to say, oh, well, no, if things are dangling off the bed, it doesn't count. Yes, it does. So you want to make sure that whatever's on that bed is the only things that should be on the bed that we're weighing. And we should also be weighing patients every single, at the same time, every single day for accuracy, which I didn't know, but now that's what I'm going to tell myself every time I weigh myself. Just wrong time of day. So glucometers, another big thing where we use them so often. We check blood sugars, what seems like a million times a day, but at a minimum for our patients' diabetes, we're checking at least 4 times a day. And so many times there's no issues. But there are, again, these patients that can be edematous, fluid overloaded for whatever reason, which can impact their extremities. And the sample we may receive, that capillary sample, may not be totally accurate. In the ICU, you can have patients, or when I was on the transplant floor, we would have patients that were sometimes so fluid overloaded that you'd be getting that capillary sample and it would all be like clear fluid, and you're like, that doesn't look right, because you need some red in there. You actually need the blood. You need that capillary sample. So we want to make sure that we're getting an accurate sample. And so those patients that you're taking, a drop, maybe you're drawing labs, you're like, oh, I can get a drop of blood out of the top of this butterfly, or from the central line. I'll just grab an extra, quarter cc. I'll use that. That's great. But the glucometer strips that are used in this glucometer right up here, those are for capillary blood samples. So if you're pulling off a central line, that's not a capillary blood sample. So we need to make sure that we're using the right samples for the correct test. Otherwise, it's not going to be accurate. And that is why sometimes there's a difference if you're checking fingerstick blood glucoses, but you're also sending it off to the lab. It's going to be a little bit different. So we always want to make sure that the QCs are done on all of our glucometers, and that we are, obviously nothing's expired, and we're also using the appropriate sample for the appropriate device. Here we go. And then some of the other things, other devices are wearable devices that patients, may be wearing at home. Our stethoscopes, which seems so silly, but make sure you're using the right bell, the right size of your stethoscope when you're listening. Wearable devices for patients, we want to be very clear with them what, how they should be using it, what they're doing, how, when they should take it off, when they should not, making sure that it's consistent and standard. So I do have another little quick poll for you guys, just to kind of find out what the vibe is now, but I may monitor my patients a little bit differently now. And Monica's probably going to take over again, but without a doubt, I'll be more aware. I might, I already nailed it.
Thank you. Yes, that poll has appeared on the right-hand side of your screen. Please go ahead and feel free to select the one answer that matches your situation. And again, the statement is, I may monitor my patients a little differently now. And once again, is it without a doubt, or I will be more aware of monitoring, or I might, or nah, I already nailed it. Okay, so go ahead and choose your best answer, and I'll leave that poll up for a little bit. And again, thank you for your participation, for being here, and for your feedback. And I will turn it back to Dr. Joseph.
Thank you. And that also gave me a little break for my ginger tea. So, but it is helpful to have that feedback of where we are with, if we're on the same page here. And it actually looks like you guys, without a doubt, 36% of you guys are gonna, may alter how you're monitoring your patients. 56 will be more aware of monitoring. 4% said I might, and 3% said nah, I already nailed it. And I love the confidence, and I appreciate that there are some sticklers for the rules. So, without a doubt, I love that. So I want to go quickly through a little case review here, and I want us to kind of let's think about it again. So now that patient that I talked about earlier, that we bumped their oxygen, we put some 2 liters on because the the O2 sat was reported to us by the PCA, and we intervened based on those orders. We had orders, right? So we based orders guided by the changes in vital signs. So was the O2 sat actually 90%? Would the patient have been in some distress? All of their vitals are normal. What might we have done differently this time, right? So we want to think about that. So for that patient, we want to think about their presentation. So looking at, maybe this time we would have taken a minute to just peek at the patient before just putting them on oxygen and see the vital signs as they were written, and really go look at the patient and look at the automated vitals machine monitor in the room. So we recycle. So this time, instead of just slamming them on oxygen, we go and recycle the vitals, and this is what we see: respiratory rate 15, blood pressure 124/67, O2 sat 90%, lungs, CTA, patient no apparent distress. Great, right? So then what's next? We've got, these are our patients, vitals, respiratory rate 16, blood pressure 130/68, heart rate 78, the O2 sat saying 90%, but look at that O2 sat waveform. That's not helpful, right? That waveform tells us absolutely nothing. What it tells us is that we're not getting the correct reading. So what do we want to do? What do we want to do next here? And what we want to do next is make sure that my slides are switching. And I don't know why it keeps popping out. My apologies, everyone. I promise it's not my first day. There we go. Okay, so we want to go to the source, right? That's where we always want to do. Go to Gemba. So you want to go to the source with the patient. You want to actually, go in and touch your patient. Not just, I know you're in the middle of something else, but you want to just go in and check the patient, check their peripheral pulses, check that they, haven't magically gotten a manicure in the last few minutes. Place the probe on the opposite hand, maybe change the type of probe, and then continuously view that waveform, right? So now that we've done all of these things, we are 1 minute in with the patient, we warmed them, we put a new probe on, and look at that. They're actually 98%, what we had hoped that they would have been. And we negated the need to give them that supplemental oxygen, which is a pretty great thing, right? So I'm tight on time, so I'm gonna go really fast here. But I want to talk about what if it was that finger stick blood glucose sample, right? So with the earlier example, we were talking about oxygen, and despite there's research that you can actually over oxygenate a patient, 2 liters isn't going to kill anyone. But when someone checks a blood sample, as I mentioned earlier, from like a central venous line from the tip, and we're normally taking capillary samples, the sample from the CVL can be shown as much, much higher. So we could actually over treat glucose level and drop someone's blood sugar too low. And that's really dangerous and can put someone in crisis. So it's something that you don't always think about, but it's something that's really impactful to the patient. So I just wanted everyone to kind of think about that. And then also some common pitfalls that we can, that happen. And they're so simple, really, but they happen a lot and they can be frustrating. So the adherence of monitor probes and leads, proper placement of those leads, appropriate lead or probe for the need of what we're monitoring, and then the confirmation of accuracy. So many times we're going so quickly that we don't always look at the waveform as well as we should. We don't always check to correlate everything, but we want to make sure that when we get a waveform, we're checking that it syncs with the heart rate, the clinical picture of the patient. We need to make sure that the waveform match and that samples match so we can properly intervene on our patients. So I just want, in my last minute here, I just want to make sure that you guys take away that monitoring is important. And I know that we know it is, but there's a reason, there's technology to match what we're looking to monitor, so that we can give proper surveillance to our patients, properly intervene, and protect our patients from allowing them to decline, and prevent them by monitoring them appropriately. So we want to match those sensors and probes and samples and the monitoring as required to what matters and what makes a huge difference in patient care. Excuse me. So checking waveforms is crucial, and any sort of dampened or over dampened waveforms are huge and should be checked every time we're monitoring a patient. So as my voice is giving out on me, I thank you guys for being with me, and I'm going to turn it over to James.
Thank you, Bridget. That was amazing, Dr. Joseph. And your poor voice. I'm so excited that you were able to power through with your voice. We'll give it a rest here because I'm going to review for everyone how you can get your CEs. There's an archive version, a couple of housekeeping things here, so pay quick attention, and then we'll move into questions because you guys have some really interesting questions, and we saved some good time for these at the end. So, as you probably remember, this is good for continuing education for nurses and RTs. We did not leave you out, of course. It's approved for 1 contact hour. So to obtain CE credits, you're going to go to www.saxtesting.com/BO. Okay? www, you got to put that all in, by the way, .saxtesting.com/BO. You will need to register once you get there if you haven't. Complete the evaluation form, and then upon successful completion of the evaluation, you can print your CE certificate, okay? Just want to have an opportunity as well to say a quick thank you to Philips again as well for this educational activity with Dr. Joseph. It was awesome. Okay. So if you missed something here, or some folks had to leave the room, or you want to go back and review some of the awesome information, there is an archived version of this available. It will be here uploaded shortly when we're done, and it's available at www.better-outcomes.org. So better-outcomes.org. Okay, an email will be sent to you who registered for this session once that is available, and the on-demand version, which is awesome, is accredited for nurses and RTs for that 1 contact hour. Okay, we're going to review that again real quick right at the end with Monica. But now, Dr. Joseph, hopefully your voice has recovered a little bit, and a couple of questions. You kind of ended with waveforms a little bit, and there's been several questions about waveforms. In particular, I mean, I feel like this is a battle from your very first clinical all the way through to, like, I don't care if you've been practicing for 40 years. Like, I cannot get a good waveform. I know you talked about it, but a lot of people ask. Couple of tips on how you can get a good waveform, again, because obviously it's so important.
So if you, it happens, and it's so frustrating, especially when something's going on with your patient and you need to just get the data, you need to monitor them, so you need to figure it out, and it's frustrating. There's so many other things going on, beeping and alarms. So if you can't get a good waveform, you're going to the source, right? So you're checking the patient. So if you're feeling their pulse, it's not reading correctly, but they're warm, they're, all of the troubleshooting tips, we're making sure that they're warm, that we're using the right probe, that it's in the right place, that we're monitoring the right thing, everything's attached correctly. Making sure that it's attached to the patient is one thing. Also checking that line, making sure that it hasn't gotten loose at the source of the monitor. As I mentioned earlier, making sure that monitor that you're using has had its preventive maintenance, so that it's actually, sometimes, clinical engineering can be a little off their game. So maybe it hasn't been checked. Maybe there's something going wonky with that monitor. Check that. And it could be something within the wire itself. So sometimes, I'll grab a different wire from a different room and leave that probe on, because it might not be that probe. It might not be whatever. It might just be the cord itself. Like, I can't tell you how many times I go through, Apple charging cords. They just all of a sudden, nope, not working anymore. And that can happen. Obviously things used in healthcare have a lot more checks and balances to make sure that they're going to last longer than a charging cord from Apple. However, things happen. And so making sure that if you try that, if you recheck that might give you what you need, and going through those. And the most important thing with that is, if it is the cord and it's not working, or it is the monitoring device, and you are able to swap it out for a new one that works, label those and take them out of service, so that they can be checked and fixed in the future, because there's nothing more infuriating than seeing a cord and you're like, wait, I already took this one out and it's back in use. So make sure that you kind of take those things, take them out so that they can be checked and replaced. But really, I think going and looking and doing those, doing the check of the patient and then checking to the monitor is huge.
Absolutely, very huge. And it can be frustrating in the heat of the moment when you're like, wait, which cord did I just take off? How am I doing this? So, even stash it in a pocket or something so you can label it later on for sure. A bunch of questions are coming in, by the way, about where to get your CEs. We're going to pop the slide up again at the end of the Q&A here, okay? So y'all can write that website down, take a picture of it, whatever you need to do, okay? So I promise you that's coming again. Dr. Joseph, this one is a little bit interesting. Turn on your pathophysiology brain a little bit. A couple of questions actually about mentioning the correlation between like low hemoglobin and hematocrit. Like I'm thinking, oxygen dissociation curves, all that kind of stuff. So a low hemoglobin and how that correlates to an accurate, SpO2 reading or like with a waveform, or if you're getting a good oxygenation reading. If someone's hemoglobin, essentially, short question. If someone's hemoglobin is 4, how accurate then is that pulse ox?
Well, so that's a great question, and it's interesting that I was kind of looking into that when I was learning about how it works and everything. But as long as if their hemoglobin is 4, that's pretty low. But as long as they have the pressure,
that was my extreme example.
No, but as long as they have the ability to get those blood cells, whatever they are, to an area of the body. So if you're, for example, if they have with that low blood volume, but we're, using whatever we are, fluids or, whatever we're giving them to pump up that blood volume so that they have an adequate blood pressure to get to their extremities. If you're on their extremities, and the light's able to get through it, it still can read. But as you guys know, the lower your hemoglobin is, the lower your ability to carry oxygen. So if we are having trouble, if a patient does have a low hemoglobin or a low crit, and it's like they're actively bleeding, and we are having trouble getting a pulse ox, most likely a patient in that scenario would have an A line. So we could look and see like where they are, like if they even have the pressure to be able to maintain that. Because that patient, we might just have to be checking some, ABGs to check what their oxygen level actually is. They may not be readable at that time until we give them, some sort of a transfusion and they're able to hold on to more oxygen, because they might be dropping down to that 80% where we get less and less accurate. But there wasn't anything, interestingly, that I saw about a specific hemoglobin level and when the monitoring gets worse. It's more about the pressure to be able to maintain it.
I think it's absolutely an important consideration. But if, like you said, if you're at that point where you have someone who is not oxygenating well at all, right, like under 90% or something, and their hemoglobin's low, you're doing lots of other things to assess that patient's perfusion, not just relying on that pulse ox, right? It's also sort of like important to understand the limitations of the monitoring that we do have. Speaking of limitations, by the way, Dr. Joseph, we have about 90 seconds left. Any more questions y'all have, get them in there. We'll try to answer them really fast. I loved this question. Any updates on devices to use on active children? And I'll add in active all patients that tend to pull off devices or get tangled in cables or things like that. So I'm, as a former ER person, I'm thinking about the kid who's maybe tripoding, having issues, or just like crazy and angry and upset, and that pulse ox keeps coming off of their ear, their forehead, their finger, everywhere.
Yeah, so with the active patient, that's pretty difficult, right? Because they are moving around. There are different, distraction techniques that you can use for those kids that are, maybe that are just like, sitting there and bored and just don't like the feeling of things. I mean, it is difficult when you have, if you have kids on the spectrum or anyone on the spectrum that don't like the feeling, that can be difficult. But using distraction techniques, using either music or getting them a drawing or talking to someone. My hospital, we use volunteers a lot to distract them and talk to them about different things so that they're not picking busy vests, and you can get for kids and not necessarily a busy vest, but it's like a busy board, so they can, pull things and open things and close things. They're still active, but at least it's going to help them. Instead of pulling off their probes, they're going to be using their fingers to kind of do something else, rather than take away our monitoring. And then you can always use, you can use those wraps, the gauze wrap around some of the monitoring leads. Sometimes the soft gauze will feel better against patient's skin, and be less apt to irritate them. You can put it under where like their ECG probes are, anything that's resting on them that feels really uncomfortable. I wish I had a magic bullet for that, though.
Great. We all do. We all wish you did. But those are amazing suggestions. And sometimes things we don't think about, like in the heat of the moment, right? That sometimes that can be really, comforting for patients to wrap things in a different way or whatever. So distraction works great. Dr. Joseph, thank you so much. Unfortunately, there's a few more questions here, but we are out of time. I'm so sorry. So I just want to thank everybody for attending. Dr. Joseph, thank you so much for this amazing, amazing information. Don't forget, we'll email you with the archive version when it's available. And Monica, you're up. Take it away.
Thank you. Immediately upon conclusion of this webinar, you will be presented with an online survey, so please keep your web browser open. We do appreciate your feedback. And again, to obtain your CE credits, please visit www.saxtesting.com/BO, register at the site, and complete the evaluation. Thank you again, and on behalf of our presenters, Saxa Healthcare Communications, and our sponsor, Philips, we hope you enjoy the rest of the day.